Hello, everyone. Welcome back again. This is episode number 2 of the ACL series that we're going over. Just a little recap on the first episode of the ACL series. Corey and I went over some of the epidemiology, some of the risk factors associated with ACL injuries, ACL tears, all of that good stuff. We went over some of the research and discussed some of the more prevalent ideas that we have regarding ACL injury and incidents of that sort. So moving forward, this is episode number 2 of our ACL series. We will be going over the next step in the process. So you got your ACL tear. Where do we go from here? So Corey will be going over some of the graft choices, some of the surgery-specific things associated with ACLs. I will be discussing some of the other aspects of it regarding should you get early surgery, should you delay and wait, is it beneficial to get some physical therapy before ACL surgery, does it matter? So we will be going over all that good stuff, and we're just gonna go right into it now. So Corey, go ahead, take it away.
All right, thanks a lot, Dave. So I was doing some research in regards to the different graft choices because, of course, that's going to be a big choice when you're looking to have an ACL reconstruction. The first place I went, I kind of referenced it during the last episode, was the knee sprain clinical practice guideline put out by the Journal of Orthopedic and Sports Physical Therapy. And they don't really give a whole lot of information there in regards to graft choice. They basically just make a few small points regarding strength deficits with each graft. Now, quickly, just to kind of go over the different types of grafts that are commonly used. The first one is, it's either an allograft or an autograft. So you're either taking a graft from the patient themselves. The different choices for those are the hamstring tendon, the quad tendon, and then what's called the patellar tendon bone graft. So basically, they're kind of taking a little piece of bone from each end of that patellar tendon. And then for the allografts, they're typically using, cadaveric grafts, and they could be of different choices. A lot of times, they're trying to use the patellar tendon bone if they can. But in the clinical practice guidelines, they found maybe some knee extensor deficits were noted with patellar tendon bone grafts, and knee flexor strength deficits noted with hamstring grafts. And that's immediately after surgery. And you might expect some of that, right? So we took a little piece of your hamstring. We might expect your hamstring to be a little bit weaker initially, at least not have the neuromuscular activation that it did pre-surgery. And the same for the quad tendon or the patellar tendon. So from there, I went to look for some different articles that kind of compared things. There was a study published in Sports Health in 2012. It was written by a group of orthopedic surgeons. It was called Anterior Cruciate Ligament Graft Choices. Basically, they just went and they analyzed post-operative outcomes of different types of graft choices, and they were trying to come up with some clinical recommendations. The first outcome they were looking at was in regards to knee stability. And there's lots of different ways to measure knee stability. They used the Lockman test, pivot shift test, and a few other more quantitative options, and they kind of discussed the pros and cons of each of those. But the first thing they stated is they found a paucity of prospective randomized controlled trials comparing allografts to autografts, and that's mostly because when you look at research in this population, patients usually have a preference of their graft choice, so that makes randomization pretty difficult to study this. However, they found one study that showed no difference in several measures of laxity between the two for a patellar tendon bone in 86 different knees. So, comparing autografts to allografts. There was 3 meta-analysis that they did with some lower quality evidence, not quite meaning that prospective randomized controlled trial. And the existing research states that there's relatively equal levels of stability between the autografts and allografts. When you compare the 3 different types of autografts, so you compare the patellar tendon bone, hamstring tendon, and quad tendon, there doesn't appear to be any major differences. One meta-analysis of 6 randomized controlled trials found no differences for laxity for the Lockman. They found some differences for the pivot shift test favoring the patellar tendon bone, but again, when you're studying this kind of test, it's a little bit subjective and it's hard to quantitate that test itself. A systematic review of 7 studies found increased laxity in hamstring grafts in 3 out of 7 studies, so a little bit mixed there. But when you looked at a few longer-term studies from 5 to 10-year follow-ups, they found no differences. Another thing they were comparing for stability was this idea of single bundle versus double bundle grafts. The thought is that both grafts can give you good stability in the anterior-posterior plane, but since the double bundle theoretically is a little bit more similar to the normal anatomy of the anterior cruciate ligament, it may give some better stability in the rotational plane, which again is the mechanism of injury for a lot of patients. One systematic review showed a 0.52 millimeter more anterior-posterior motion in the single bundle group, but there were no differences in the rotational group. And the author stated an issue here is that when they did the rotational measurements, they used that pivot shift test. Again, so that's, it's going to be hard to pick, when they're measuring 0.52 millimeters, it's hard to pick that apart in a pivot shift test. There was one study they found that used a 3-dimensional electromagnetic sensors to detect that motion, and they found increased acceleration of tibial motion during the pivot shift test for the single bundle group. So that's potentially giving some evidence that the single bundle group may be a little bit less stable in the rotational plane. And due to the recent rise of the use of the double bundle, there's no long-term studies. So basically the article concludes that there's not enough information to suggest one over the other, but we are seeing these double bundles done a lot more often at this point. Is that something you've seen a lot of, Dave, between your patients?
I haven't actually noticed too many double bundles surgeries. There are a few, but I feel like I get maybe it's just a difference in the surgeons where I am versus where you are. But it seems like it's still mainly single bundles that are going on.
Yeah, I would say I actually get a little bit of a mix in it. Again, it's going to depend on what surgeon they have and what sort of preferences that surgeon might have. Mm-hmm. Because I feel like that's one that patients usually don't really care about, right? They're, okay, we're going to do a single bundle or we're going to do a double.
Yeah, just get me better.
Yeah, exactly. So for strength as an outcome, this study actually found that there was some conflicting evidence. It generally seems that there's no major differences in quad strength between autograft bone patellar tendon bone grafts and hamstring grafts, but there's mixed evidence that there may be differences in hamstring strength. Now, none of these studies compared autograft to allograft. These are all just autograft patients, so the graft is taken from the patient themselves. And then for function, they used the Cincinnati knee score and Lysholm, and there appears to be no differences there between autografts and allografts. So for strength, again, we mentioned before in the clinical practice guidelines that there may be some short-term strength deficits between the two grafts, whether you have a hamstring or a quad tendon. But when they looked at a bunch of different studies, it's kind of mixed evidence. And to me, I just take that as, that's where you got to use your clinical reasoning as a PT, right? You're in that protective phase immediately after surgery, and then you want to try to get the quad and the hamstring up to their pre-injury levels, whether that's just isolated strength of the muscles or, using them with co-contraction and activities like squats and things like that. So a few more outcomes, and then I just want to read the clinical recommendations from the study here. The first is that allografts did not have a higher infection rate than autografts. That's one that people commonly looking at is because we're getting an allograft from a cadaver, is there an increased risk of disease transmission or infection? And from the available evidence, they didn't find any major differences in infection rate. One of the things they did find a slight difference in was anterior knee pain. Again, that bone patellar tendon bone graft, they're taking that graft right from the patella, a little piece of that bone, and they found it correlated with a little bit higher levels of anterior knee pain than the hamstring tendon grafts did, and this was during a 10-year follow-up. Again, that's something that I have found some elementary studies that gap that you get, when you take the bone patellar tendon bone graft, there's a little bit of a space now that you can almost palpate in the patella where they took the graft. And there is some studies that starts to become fibrous over time, and that space may fill up a little bit. However, that's a little bit conflicting too. And then the last outcome here that they talked about was graft rupture. And there doesn't appear to be any differences in regards to graft rupture among the 3 autografts and between the autografts and allografts. However, they did find a slightly higher rate of failure of allografts in younger patients. And we'll see that come through in what their clinical recommendations are. So, their clinical recommendations. Just give me a moment because I want to read them word for word. They're pretty well done. The first one is, while bone patellar tendon bone autografts may provide the best short-term stability because of their faster intratunnel healing. And again, that's really the reason they do it, is they have that bone on both ends of the grafts, and they're thinking that's going to heal a little bit better into the tunnel that they established for the anterior cruciate ligament reconstruction. But while they have a better short-term stability, long-term stability appears to be equivalent among the 3 main types of autografts. So as far as knee stability goes, being able to reproduce any sort of motion in a Lockman test or pivot shift test, they all pretty much seem to be equal. Few differences exist among the graft options for muscle strength, function, return to sports, and patient satisfaction. So again, this is a good one for our patients, is that they seem to do pretty well regardless of the graft type there. As far as complications, once again, the bone patellar tendon bone autografts may lead to higher rates of anterior knee pain, especially when they're kneeling, right? So if they're getting down and kneeling on that spot where they've had their graft taken from. But there's no evidence that any graft option has a higher rate of postoperative infection over any other graft option. The risk of HIV or hepatitis transmission with allograft use is very small. There's evidence for and against allografts having a higher failure rate than autografts. So again, it's basically they suggested that there was no major differences, but it's a little bit mixed right now. And again, that's bringing up the point of the allografts seem to fail a little bit more in the younger patients, which is why they tend to use autografts. Again, that last part of that recommendation is allografts should be avoided when possible in younger, more physically active patients because of the high rate of failure in this population. And the last recommendation here is the data on the comparative cost of the graft types is not overwhelmingly in favor of one graft over another. That was another outcome they used, was cost. They were looking to see, does it cost more to get an autograft versus an allograft? Basically, they found there were no major differences there. A quick little side note, because that's the end of my article there, but one of the things they're starting to use a little bit more now is these synthetic grafts. Dave, have you seen anything on these?
I have not, actually. No. I've seen. I mean, they're trying to do some new stuff with like blood clotting that's going on, but I haven't seen much of what you're talking about with synthetics.
And I haven't either, to be honest. So this is one they brought up, and again in the study, as with a lot of systematic reviews, they find that there's not a whole lot of evidence there in general, especially long-term studies, because this is a relatively new thing. But it is something that patients, you may be seeing in your patients now that they're using these synthetic grafts. And again, there's not a whole lot of data to draw from in regards to this. Mm-hmm. But that's the end of my article. Dave, what do you got for us?
Fantastic. So just as a quick little aside as well before I jump into my topic area and articles is, whenever I discuss ACL grafts with patients or really anyone in general, the big question comes up, kind of like what you said, is, which kind of graft do I do? What do I do, really? And then my usual advice to them is, well, listen to our podcast that we just put out, so wonderful. But no, usually what I say to them is go with the surgeon, go with what the surgeon is most comfortable with, You should go to a surgeon, A, that's done a lot of ACL reconstructions, and B, whatever particular one that surgeon uses, I would recommend sticking with that. Because as Corey had said, as he had just gone over very well, is that, there's not much difference between the two, right? So go with what the surgeon is most comfortable with. Would you agree there, Corey?
I agree, yeah. I say that actually for a lot of surgeries is, number one, you want to find the guy or girl who does a lot, right? You want the person who does like 100, in a week versus, does one every few months.
Yeah.
And again, when you find a surgeon like that, they're going to tend to have their own preferences. And I think based on the evidence as far as recovery and graft rupture and infection and all those different things we talked about, there doesn't seem to be any major differences. So you can, of course, go over the pros and cons with the surgeon. But I think going with what the surgeon is most comfortable with can be a good choice.
Yeah, definitely. So that is, I would say, probably one of the big like clinical pearls that I would pull from all this, is that there isn't much difference between the two, and go with what the surgeon's most comfortable with and the one that they've done the most. So very good. All right, so moving on to my topic areas, my the stuff that I looked up. I went into, so you tear your ACL, and now you're at the point, well, okay, when do I get surgery? Do I get surgery? What happens here? So I went through a bunch of literature on this topic, and essentially my question was, in the long-term outcome, is it better to get the ACL reconstruction done early, or is it better to wait, delay it, and then go from there? So there's two different schools of thought. One is that, you get it done earlier, and because you get it done earlier, that means you could return to sports and activities earlier, right? So that's the one thought, you go and you do that. The second thought is you need to delay that surgery, in order for what comes up in the literature a lot is a quiet knee. You want to get what's termed a quiet knee, which is very minimal swelling, barely any swelling in the knee. And then you got, strength is all there. Range of motion is essentially normal. And that knee is, other than that torn ACL, the knee is good to go, right? So that's the other thought, because it reduces post-operative complications is what the thought process is. Again, you have a quiet knee, and therefore you don't have this arthrofibrosis afterwards. And then the rehab is quicker. It's better rehab. So two schools of thought there. I'm going to go through a bunch of articles and commentaries and reviews on this topic, and we'll see what they say. So to start off with, there was a study done by Smith et al. From 2010, again discussing whether this early versus delayed is best. So what they found, just to sort of break it down real quickly, is that there was no statistically significant difference between the two outcomes based off of a 2-year follow-up. So essentially what they did, they took a systematic review of articles. This was from in the United Kingdom from 1985 to 2009. And they took 161 people that did the early ACL reconstruction compared to 209 that did the delayed ACL reconstruction. And again, no real statistically significant difference. What they did mention was that the degree of injury to the knee, rather than the time from injury to surgery, is the suggested factor that plays into all this, right? So if you just have an ACL tear, pretty simple, straightforward, then it doesn't really matter whether you do early or delayed. But if you have this ACL tear with meniscus tear, MCL tear, all this together, then that's more of a factor into whether you should do early versus delayed. So that was one. Next, for staying in 2010, there was an article by Frobel et al., which found, again, no significant difference between groups that had rehab and a delayed or optional ACL reconstruction versus those that just had, the quick early ACL reconstruction and then rehab. They did a 2-year outcome, which was measured by the Koos scale, which is it's a subjective patient, essentially a questionnaire that patients fill out as to, their functionality. And they did this 2 years after all this was said and done. So from injury to 2 years, that was their time frame. What they said was there was something actually really interesting in this article as well that said those in the optional or delayed reconstruction group, they had fewer rehabilitation visits than those in the early reconstruction group. So again, we're talking about cost effectiveness and all this. And maybe this study found that, from the amount of visits perspective, there's less in those that delay the ACL reconstruction and do the rehab instead of the reconstruction. So what happened was this orthosurgeon, Bernstein, from 2000, and he wrote a commentary in 2011 about this article by Frobel. And essentially, he said that early surgery may be more effective approach overall based off of other complications involving the ACL. So, for example, if someone developed a meniscus tear as well, then you might have to look at an early ACL reconstruction as opposed to delaying it. I think there was just a little animosity there from this guy. I don't think he was too happy showing that people did pretty well without an ACL reconstruction and delaying the surgery. So, but it was an interesting commentary take on it. So just a couple more here. There was an article by Herbst et al. In 2017, so pretty recently, and they found that an acute ACL reconstruction within 48 hours of injury is preferable in highly active patients or competitive athletes. So again, like I said, there's this fear about doing a quick early ACL because there's just a recent injury there. There's a fear of arthrofibrosis or stiffening of the knee if you go in there and do surgery quickly after injury. And what this study showed was that people did pretty well, especially if you're a competitive athlete, if you get the surgery done early within 48 hours. And they said that the outcome of an ACL reconstruction does not depend on surgical timing because they had people in a delayed group, which also did very well. So there was that. And then lastly, there was an article done by Folstrom et al. From 2016 that essentially they found what factors predict poor outcomes from an ACL reconstruction. And some of those outcomes were if they were of younger age, if they had the ACL reconstruction done early, and then if they injured their knee while playing football, or as we call it in America, soccer. This was done in Sweden. So those were the main factors that predicted a revision or a contralateral ACL reconstruction. So the predictor of time between injury and surgery should not be the main focus. Instead, it is that early ACL reconstruction is performed on highly active competitive athletes who desire to return to strenuous sports. So essentially what they said, it mainly depends on the athlete or the individual themselves that determines these outcomes. So very interesting stuff. A little bit mixed in the literature, but I think my big takeaway from some of this was it depends on the individual, right? It's very difficult to generalize ACL reconstructions because everybody's different. Everybody's knee is different. There's biomechanical factors that play in. There's psychological, social issues that come into play, age factors. So there's a lot that goes into it. So based off these studies, a lot of them found that it doesn't really matter if you get it early, if you get it done later. Essentially what it matters is the severity of the injury of the ACL and the other knee soft tissues and the individual themselves. So that was the big thing. Corey, what do you think?
Yeah, I think based on like what you've given us as far as the literature goes, it could kind of go either way, right? I think patients are going to do well regardless of what strategy they decide on, and it should be individualized. So, to me, someone who has a knee that's been, blown up and is huge, very swollen, I think it's probably a good idea to let that knee calm down a little bit. Again, the research could go either way on that. But even from a patient fear perspective, or potentially even a activation of the quad, all those different things, to me, I like to believe that if we can get good quad activation going in, it should hopefully help coming out. Again, the research could go either way, but that's something where And in regards to knee range of motion too, right? If they're having a hard time even getting negative 10 degrees of extension, I think it's worthwhile to go ahead and try to get 0 before you go in.
No, I completely agree, which is why I was a little bit taken aback by that one study that showed that these people got their ACLs reconstructed again within 48 hours of surgery, or within 48 hours of injury, and that was something that was completely just shocking to me. Again, the study comes from the journal Knee Surgery Sports Traumatology Arthroscopy. I don't know. It was a very, very interesting journal. Very long name.
How did they get an appointment that fast?
Yes, I know. It was absolutely incredible. So again, it's from Herbst et al. The title of the article is termed "Impact of Surgical Timing on the Outcome of Anterior Cruciate Ligament Reconstruction." And again, the average time for people that did the early reconstruction was 1 day. Essentially 24 hours, you get injured, boom, you're in the OR. It was pretty interesting. And again, there was no real significant difference between the two. So, I guess a lot of it does depend on the individual, so very
another point too, it might even depend a little bit on the surgeon there too, right? If the surgeon is a little more comfortable going in with less swelling and better range of motion, maybe that's what you go with, or vice versa. If the surgeon wants to get you right in, thinks she can get you a better outcome immediately, I think both are good options.
Another thing that we need to point out though with this is that the definition of early is very different amongst these studies, right? So again, in that study we just mentioned, it was early was considered less than 48 hours.
Right.
In some of these other articles, early is considered less than 3 months. So again, a very drastic difference between this and a lot of the other studies. Again, kind of like what we've been discussing a lot, there's a common theme here in a lot of this literature that is we have poor definitions of what all this stuff means. So, we had discussed about the dry needling a couple weeks ago that, there's a poor definition as to what dry needling exactly is. A lot of people just lump it in with acupuncture. Some discuss other types of dry needling. So the factors there are very different. And then same thing here, right? The definition of what early surgery, ACL surgery is versus delayed is very gray. It's very mixed. And until we get these definitions really figured out, then it'll be difficult to move forward and really get better recommendations to people. And it'll be difficult to really develop these high quality studies as well.
Yeah, and it makes comparisons of the studies really hard.
Very
difficult. When you're trying to look at outcomes, from one study to another, and you're trying to compare what they did in that one study versus another, if their definitions of early, like you said, if they're lumping in early being 2 days versus early being 3 months, that makes it really hard to draw conclusions from because the studies aren't that similar. And It's a huge area, huge issue in physical therapy research, and it's why that if you're looking to be an evidence-based therapist, it's not quite enough to do a conclusions read, right? You got to kind of get in and see what they're doing because some of the way you word things to patients and some of the advice you might give might be a little bit biased based on what they were doing in the study.
Right, and again, I believe we talked about this before, but it's important to It's important to bring it up again is that there is natural bias in all these studies, right? So again, we need good definitions. We need solid systematic reviews, meta-analyses to really bring all the data together because again, if I am an orthopedic surgeon that loves to do ACL reconstructions, then I'm going to really point to some of these articles that say, hey, it's important to get it done early and to get it done, as soon as possible to prevent any further complications down the road. So, and then vice versa, as a physical therapist, I may be more inclined to tell people, hey, come to physical therapy, hold off on the surgery, and then see where you're at functionally, a month or two down the road. So, again, it's take everything with a grain of salt. And then, again, I would say look at things individually. But there is one other topic I want to bring up that I was looking at, and that is whether we should do prehab or prehabilitation with these ACL people. So again, before it was whether we do early or delayed, and now it's, for those people that are slightly delayed, should we get them into physical therapy before the surgery? I'll just come right off the bat and say I 100% believe that these people should come in before they get any ACL reconstruction surgery done. The stronger you are going into surgery, the stronger you will be out of surgery afterwards. That is my personal opinion. Corey, from what we've discussed so far, I believe you feel the same?
I do feel the same, yeah. And I feel the same for a lot of reasons. Number one, like you said, you can get better strength, better activation of the quad, the glute, the hamstring, and if you're worried about an unstable knee, you can do a lot of that in a relatively unweighted position. You can get them moving a little bit better. If they tend to lack some extension, you might want to be working on gait with that patient. But also you can start to at least introduce some of the things that they're going to be looking at after surgery. You can show them some easy ways to go ahead and do range of motion after surgery and give them the little tips that normally they'd have to wait a little bit after surgery to get.
For sure. So one of the studies, I looked at a few, but one of them that I really want to highlight is the study from Von Melich et al. 2016 is when this was published, and it's a really cool study. Corey, to be honest, I kind of have some props to give to our European counterparts because I really think a lot of the stuff they're doing over there is just fantastic. I look at a lot of the research that comes out from Europe, especially in some of the Scandinavian countries, Sweden, Norway, Finland, these types of areas, and I think they're doing just some really great work over there. Something that we in America should kind of look to a little bit. But I don't know. That's just a little aside here. So this one study I want to bring up from Von Melich et al. 2016. It's termed evidence-based clinical practice guideline, evidence-based clinical practice update. It is practice guidelines for ACL rehab based on a systematic review and multidisciplinary consensus. So what they do is essentially they term it a clinical practice guideline underpinned by systematic review and expert consensus, which I think is just a really cool way to sort of term it. And it comes from, now this is also something I love here, okay? It comes from the Royal Dutch Society for Physical Therapy. Is that not the coolest thing ever? I love the American Physical Therapy Association. I love the APTA. They do wonderful stuff there. But come on, the Royal Dutch Society for Physical Therapy, that's just badass. That's just, I just love that. So again, this was kind of like a CPG, kind of like how we have our CPGs. They have their own. And essentially what they did was their level of evidence is graded from a 1 to 4, a 4 being expert opinion, and a 1 being just super high level based off of research, all this, that, and the other. So they looked at preoperative predictors for post-operative outcomes. They found 10 articles, and this is essentially what their summaries were or what their conclusions were. So they had level 2 evidence that stated a preoperative extension deficit is a major risk factor for an extension deficit after ACL reconstruction. So again, kind of like what we talked about before. If you have this negative 10 degrees of extension, it's going to have some negative outcomes after ACL reconstruction. They also had level 2 evidence suggesting that a preoperative deficit in quad strength of more than 20% has a significant negative consequence for the self-reported outcome 2 years after ACL reconstruction. So again, something that we can affect, something that we as physical therapists can improve is this overall quad strength before going into ACL reconstruction. And lastly, they had level 3 evidence, so, kind of bringing it back a little bit. But again, level 3 evidence that prehabilitation ensures better self-reported knee function up to 2 years after ACL reconstruction. So we need a little bit better studies to give ourselves some props, some importance in getting into prehab. But again, this study found that there is some evidence that shows that there is some important differences between those that get prehab and those that don't. So those are the studies sort of wrapping up all this. Corey, if you had any kind of just major takeaways, what would you give to them?
Well, for the therapists listening, I think one of the major takeaways from what I was talking about is that you're going to have good success with any of the graft choices. It seems that the younger, more athletic patients tend to do better and have less re-tears with an autograft versus an allograft, so with that self-harvested graft. And, when you compare, among the rest of the population, not being necessarily a younger athletic population, it doesn't really matter what you use. So what you can discuss with them is, based on their goals, based on their functional level currently, what they want to be able to do. Is this someone who is a competitive athlete of some sort and wants to get back to sport as soon as they possibly can? Or is it someone who wants to move along their activities of daily living, maybe some exercise, but wants to be able to squat and pick something up and things like that? It should be patient-centered, certainly. But also you can tell your patients that, hey, find a surgeon who you're very confident with who does a lot of these surgeries. And, for the most part, again, what we have as far as research goes, what they're most comfortable with might be your best choice because, all of them tend to do very well.
Yeah, 100%. Agree with all that. Again, just to wrap up, I would say graft choice is not the big thing that people should focus on. They should be more focused on what surgeon is performing the reconstruction of the ACL. Again, I've seen it before. I've had people come in with surgeons that that is their specialty, ACL reconstruction, and they do incredibly well. I've had people that come in that get surgeries from surgeons who are kind of just a general orthopedic surgeon that does a little bit of everything. And again, things are a little bit tougher, so there is definitely some difference. There's a major difference, I would say, in the surgeon that you choose to do your ACL reconstruction. So I would look at that more than which graft you take. And then also going forward, I think the research is pointing more towards prehab. And then, if you want to have a surgeon that doesn't want you to get it, then I don't know, maybe look somewhere else. But, I'm biased. Obviously, we admit this at the start, but I think that people should get some prehabilitation done. Get super strong, get all your range of motion, and get as fit as possible before going into ACL reconstruction. Again, it doesn't take much. Maybe just 2-3 weeks of just really hammering home some of these things and then get the ACL reconstructed. So it doesn't have to be much, but I think it is something that will benefit you in the long run. And that is our recommendations. That is what we found. That is what we believe. And that's about it.
To kind of lead us into next week too.
Yep.
I think the surgeons are obviously a huge role in this, and that's why we kind of split this up into 3 different episodes. We kind of wanted to take it through the separate phases. And what we're finding out too is both pre and post surgery, the physical therapists have a huge role in how well these patients are going to do.
Yep.
And there is a pretty high re-tear rate, which we found from the first episode.
Yep.
So that's on us a little bit. We got to get these patients ready to roll. They not only need to be able to produce good strength, good range of motion, in those early phases after surgery, but eventually it's return to function time. When we're through that protection phase and we're really working on functional activities, whether it's jumping, cutting, running, those are things that have to be addressed at a certain point during the rehab process.
100% agree. And it is very important that we obviously, A, get them to that point, but B, that we are capable of giving them the tools they need to get to that point. So, again, really looking forward to next episode. We will be discussing in more specifics what it takes to get them to that, return to sport phase. We'll be going over maybe some of our little tips and tricks that we have for these patients, and then again, more research-based, evidence-based look at what we need to be doing. We will also be presenting a patient case to wrap it all together starting next week, and we look forward to everyone tuning in then. As for now, though, that is it for this episode of PT Forensics, and check us back next week for our final installment of the ACL series for return to sport and intervention. So thank you, everybody, for listening. This is PT Forensics.